Meningitis is an inflammation of the meningeal tissue surrounding the brain and spinal cord. People with compromised immune systems and those who live in community close quarters have a high risk of contracting meningitis. It can result from viral, bacterial, parasitic, and fungal infections. These organisms usually gain entry to the central nervous system through the upper respiratory tract or bloodstream, but it can also enter by penetrating wounds of the skull. Inflammation occurs as a result of the infection and increases intracranial pressure. The infection can spread through the cerebrospinal fluid. Bacterial meningitis has a mortality rate of nearly 100% if left untreated.
Subjective clinical manifestations of meningitis include fever, severe headache, nausea and vomiting, neck stiffness, increased sensitivity to light, and confusion. Objective clinical manifestations of meningitis include a skin rash and petechiae that can be found on the trunk, lower extremities, and mucous membranes, coma that is associated with a poor prognosis and occurs in 5 to 10% of patients with bacterial meningitis, and seizures that occur in 1/3 of all cases.
When a patient has manifestations suggestive of bacterial meningitis, a blood culture and CT scan should be done. Diagnosis is usually verified by doing a lumbar puncture with analysis of the CSF. A lumbar puncture should be completed only after the CT scan has ruled out an obstruction in the foramen magnum, in order to prevent a fluid shift resulting in herniation. Specimens of the CSF, sputum, and nasopharyngeal secretions are taken for culture before the start of antibiotic therapy to identify the causative organism. X-rays of the skull may demonstrate infected sinuses. CT scans and MRI may be normal in uncomplicated meningitis. In other cases, CT scans may reveal evidence of increased ICP or hydrocephalus.
Common medications are IV antibiotics ampicillin, penicillin, cefotaxime, ceftriaxone, coating for headaches, dexamethasone, acetaminophen, phenytoin IV, and mannitol IV for diuresis. Treatments include prevention through vaccination, such as influenza or pneumococcal pneumonia vaccines. Other treatments include drug therapy, nutrition therapy, occupational therapy, health promotion, and antibiotics.
Some nursing diagnoses related to meningitis include acute pain related to muscle aches and headaches, hypothermia related to infection, impaired physical mobility related to nuchal rigidity or neck stiffness, and activity intolerance related to fatigue secondary to infection. Most potential complications that occur from meningitis are due to the increased intracranial pressure. This increase in ICP is what typically causes an altered mental status in these patients. The main prevention will be monitoring for signs of increased ICP, such as hypertension and bradycardia. An increase in ICP may cause compression on cranial nerves, leading to blindness, ptosis or drooping eyelid, unequal pupils, diplopia or double vision, facial paresis, tinnitus, vertigo, and deafness. These complications usually resolve in a few weeks, but may be permanent. Until treatment is completed, patients may experience headaches due to the inflammation. Shock can occur from the overwhelming infection and can cause a life-threatening condition called DIC, or disseminated intravascular coagulation. DIC causes extreme bleeding from decreased platelets and clotting factors, predisposing patients to hemorrhage.